Take two. Hey folks, my name is Rachel Mason. I'm a second-year medical student, and thank you so much for being here today at our Office of Diversity, Inclusion, and Belonging Symposium. Today we have two wonderful speakers. We have Dr. Ali-Dinar and we have Dr. Rankin, who's joining us virtually.
Thank you so much for the opportunity, certainly to Dr. Johnson, first of all, for asking me to be a part of what you're doing outstandingly so in diversity and equity and inclusion, and just some of the work with also Dr. Gray that I've been able to do with the Global Health Summit that Creighton helped partner us with for tribal health and for the One Health Initiative. And so I'll try to take some of the things. If you attended last year, you'll know that I said that everything that's important is about recognizing that we are a tribe of humanity. And this year, I'll also build on that, along with we're only as healthy as our least healthiest patient. So when we take a look at the context of the importance and the gravity of your work and what it transcends to be, I'll try to tie together a lot of different themes. This year, I'm going to speak a lot more about what's happening globally within DEI, and then another DEI context that you can apply. As Rachel mentioned, I was the CEO of Ponca Health Services and interim of Tribal Affairs for CEO, and I have since now kind of graduated into a bigger, broader role that allows me to really tap into where I've been for the last 7 years as CEO and COO of Self-Care for Healthcare and working with Jubilee Health and the United Nations. So it'll help you recognize that while your work is taking place here at Creighton, the context of what you have to learn, to offer, and to give back is globally. And so I'm really excited about what I have to present, as well as active listening to what you all have to say in relationship. All right, so you, as your physician's purpose, are a gift to the tribe of humanity. You yourself, as anybody, are the entire universe. And so you deserve the love and affection that you have for yourself. And I think that there's so many more demands upon being able to correctly diagnose what a patient has. It's the diagnosis of also self-care, listening to your inner self and how you fit into that. And what are you doing to give yourself grace to champion all of the needs moving forward? You know, last year when I spoke, we were just barely 1 year post-COVID. And, you know, as we look at COVID, we're taking it through the lens of DEI wellness. And so we know that there's a huge recruitment retention shortage by the 2030. And so while I have a lot of text, I also think it's important from an academic standpoint that you know where some of this material derived from. But I also think it's important to know the context of which it's derived from. So the most important piece on there is obviously what's in red. It's that 18 million healthcare workers by 2030 will be a shortage. That will cost the marketplace $47 trillion. So when you think of it in the context of if you're a rural healthcare provider, and that's a critical access hospital where you're providing care to a rural health clinic, to a critical access hospital in a community that's anywhere from 1,000 to maybe 10,000 people, you as physicians have an impact driver of $2.8 million. When you're in a larger suburban area, you as a physician have an impact of anywhere between $5 and $25 million. So that's just the impact of what you're generating in reimbursements. It's what you're generating in building more capacity, more employees, more employment opportunities. So the ripple effect is gargantuan. That's why you see 47 million. So when you think about how important it is, physicians, all clinicians, that's what your dollar impact is on the marketplace. Now, only imagine that if we have a shortage, what that impact is on individual and family wellness. All right, so we look at how many deaths were COVID related. And of course, now since we're in another year, we find that there are even more variants, even more types of respiratory distresses, long COVID, as they call it, and what those adverse effects are. And of course, on chronic disease wellness, what the additional impacts have been. Also, since last year, we see that when we take a look at the tribe of humanity, let's look at the global creation. So, last year, myself and then the CEO of the Omaha Chamber of Commerce, she mentioned location, location, location. And I remember when I was working for the Beverly Hills Chamber of Commerce, it was all about 90210, location, location, location. But the zip code is so important. And I think as she had captured it last year in her presentation, it was just in the city of Omaha. You could be across the street and it have an impact on lifespan of 10 to 20 years. So when you look at the cascade of what that means for global health, we find in just this last year, there are more inequities, more distresses globally. There are 35 plus more wars than there were last year at this time. Some of them aren't even making the headlines because there's too much. There's always something that causes more headline focus, but that's a lot of wars. And then you think about with that comes increased diseases, increased malnourishment, starvation, gene, government, and genocide, social inequities, access barriers, violence in the workplace and communities, environmental balances of air and of water and of the animal kingdom. And so as we live in a more global community, we recognize that we have community members that are also global in outreach, speaking different languages, celebrating different religions, and they happen to be here studying or living, but our backyard is a global backyard. And so again, from the context of DEI and who you are as physicians in the make and making, this is important to think about. I look at this, and this was taken a few years ago, and when the first genocide took place in Sudan. And although I'm originally from Nebraska, my husband is part of the Kira dynasty. His family ruled Sudan for 1,200 years. And his grandfather was assassinated in 1916. And since in just Sudan alone, there have been several government changes. When we look at this is, it could be a lot of things. It's not just a starving child, and it's not just the vulture, but that's the paradigm shift that we see in a global community about diversity, equity, and inclusion, and how important it is. We can look at this picture and we can say that the vulture is waiting for the child to die, but we know the vulture as a predator could be any name. We know that the child could be any name. And so it's important for us to vision map what equity, what imperatives and disparities are that exist in this world. So when I speak from the United Nations standpoint, I'm speaking also about all of these things that are in Nebraska, these things that are in DC and New York, and these things that are across the world. So from a United Nations standpoint, from the DEI, we look at it from the sustainable development. No poverty, zero hunger, good health and well-being, quality education, working our way down. We can't believe that there's 18 different variables working down to sustainable development of goals. Now, I have the opportunity that since I've transitioned as a CEO from tribal health, which is still near and dear to my heart, I really represent now the work through Self-Care for Healthcare, which is the original chicken soup for the soul, United Nations and Jubilee Health. And we work with 100 different healthcare systems across the nation, many of which many of you here in this room and virtually will recognize. So DEI now is really looked at the context of health equity, bias sensitivities, access barriers, social determinants of health. And if you're a practicing physician, you know that there are G codes now that you can also apply as you look at patient-centered healthcare and you look at, do they have food security? Do they have education security? Are they suffering from mental disease or mental welfare that they need? Is there elder abuse? Is there domestic violence? Is there secure housing? It's looking at more than just a person from a disease diagnosis, but who they are in the social spectrum. Population health and public health, how we interweave and intertwine that. In a pre-COVID world, public health was looked at as something that the public health departments do. It's not really anything that we're responsible for doing. Then when we all wore masks, it was our individual role to protect one another and ourselves. But from a broader context, there is a lot of diversity, equity, and inclusion as it relates to our role of public health. We're all responsible for lifting up one another, for providing the best healthcare and information that we possibly can, and being good servants and stewards to one another with those knowledge and with the resources. It's mastering your mindfulness and being deliberate in your presence. I often still tell my physicians, I said, the best thing that you can do is remember, it's not about necessarily the diagnosis. You know, the complexity of our bodies are that there are things that are trillions of cells and enzymes, and the brain has 3,000 different kinds of cells. It's not so much about the correct diagnosis. That is a journey. It's also just being present for that patient, knowing that at that given moment, you could be delivering them their best moment. And when you think about it from that context, that is a treasure. And then Pantry Plus. You know, for many of you, you weren't born yet when there was the Marcus Welby, which is on TV land, if you all are interested to know. But that was the physician going out with his leather satchel, and he was going door to door. And we're returning back to that. But now we're returning back to that more than with just a stethoscope. Now, most of my physicians, when they travel out, they're traveling with little care packages, pantries, mini pantries, if you will. They're traveling with their cup of soup, making sure that they both gift and provide a diagnosis for patients. So it's much more home health based, much more holistic based. And then medical outreach and reaching out and the patient centered, it's meeting the patients where they are, not where you'd like them to be. That's part of the journey, but it's meeting them where they are. And that's where equity, closing the gaps on disparity, biases, and equity are so important through the social determinants of health. And then delivering those basics, but yet delivering them from an innovation standpoint, recognizing that to get them at their best health may continue to change. Rachel and I were talking about, myself continuing to pursue more education degrees. And I said, the genesis and genius of it is that you still have to interact in the classroom. You just can't read 20 different types of platforms daily and think that that's what keeps you engaged. You have to recognize that things keep changing. You have to keep yourself fresh, and you have to recognize that the contemporary things are happening even as we sit here and we speak. So when we look at, again, looking at the red being the most important, that the overall recovery of self-care stress for the next 5 years. So part of my work is through the 6 surveys that we've provided is to close the gap on the $100 trillion that'll be lost in the marketplace due to hatred, racism, budget cuts, operational cuts, misinformation campaigns, inequities, access barriers, and lack of DEI, whether it's in the universities or it's applied as physicians to their care. But that's also through the World Health Care Organization. So part of, if you remember, for those of you who may have attended the Global Health, Tribal Health February conference that Creighton held, we talked about the One Health Initiative. And the One Health Initiative is recognizing that we all share the same world. We share the same globe, no matter how big or how small we make it. But that our water, that our air, that our animals, our pets, we all share that same area. And so we have to recognize from a perspective of what is the value proposition and how can we thread that all together. I'm fortunate that I was selected from the National Rural Health Association, which I serve on Rural Congress and a liaison to the White House, that we now want to make that as part of the policy. So then Governor Pete Ricketts had chosen myself to oversee Nebraska's child maternal health wellness initiatives. And now with Governor Pellin, who is also a farmer, he recognizes the One Health Initiative, that through their support, through our initiative support, through UNMC, and hopefully what Creighton will continue to do, that we'll be able to capture this as Nebraska being one of those that not only wants to pursue that, but live it and really help adapt it to medical school and other types of public health initiatives. And then what we can do within the academic institutions and population of public health across the United States. So look at Nebraska being the center for more policy in that area. And then recognizing that diversity, equity, and inclusion can belong in town hall meetings. I often ask my physicians to, introduce yourselves, have a virtual town hall meeting, get to know your community members, give back long before you are called of service. Get a chance to know what you have laid before you and those other skill sets that you have that are beholden unto you by the Creator that make you special and unique. Recognize that innovation, it's not necessarily if you believe in AI. There's lots of different kinds of innovation. I have 2 innovation models that are at CMS that will really help close the gaps on the disparities through oncology and psychiatric care for rural, for VA, for those that are refugee, those that are minority, to really help uplift them from being one of the disengaged to be one of the healthiest of our communities. And then applying work-life balance. I also told Rachel that I'm not one for 7 or 8 hours of sleep, but when it calls crashing to me, I have to recognize that even though I teach work-life balance, I have to constantly be diligent and present to practice it myself. You as physicians will be called more than ever before to try to strike that balance, to make sure that you don't burn out or that you rust out. That's a new term that's being used. Burnout is that I have nothing more to give. I have nothing left in my tank. I have nothing left in my cup. I have nothing left in my soul to give. Being rusted out is I'm not operating at the top of my game. I'm not operating at the top of what my certification is or what my certificate is or of anything that I've learned. So rusted out can be your nurses. It can be your support system also. And what you're doing to bring harmony to the workplace to keep people engaged and in alignment and recognition of that before it happens. It's changing the stigma in case you need behavioral health resources or that you can openly own up that maybe you're not at your best right now. Maybe you do need to seek additional support. It's okay. Physicians have always been held in that highest esteem, as you should be. But as treasures in the healthcare, at the center of healthcare, you also need to recognize that you're a mind, body, spirit. And you also need to recognize that sometimes being your best you is also engaging with others, asking for help. And that's actually a strength. It's not a weakness. So changing those stigmas, and then a toolkit of resources, recognizing that you don't have to know everything. It's okay to say, I don't know everything right now. I'll get back to you. But what other types of surveys and toolkits do you have access to? So the Tribe of Humanity creation physician focus is investing in your children. It's recognizing your welfare mix, and that's more than just Medicare and Medicaid. It's really recognizing social determinants of health, providing them a safety net, whether it's with reimbursement, G codes, the pantry, or other types of sources and resources. Now I teach my physicians that it's not so much about just the diagnosis. When that patient leaves, whether you're using a teach back method or not, you should be giving your patients a gift basket of knowledge. They should be leaving with as many resources that you have on your fingers, one hand, at least 5 resources that they can feel engaged with. Creating a support and meaningful employment system, recognizing aging through the life course, promoting healthy lifestyles, and the universal access to high quality healthcare. DEI from a value proposition, whether you're in the medical schools or whether you are in the community, I told you took on another DEI. So it's not just diversity, equity, inclusion. It's consistently delivering, being dedicated, being excellent, and operating in high level of integrity. So we know that there are 8 sounds in the vibration of the universe. And the top 2 sounds, F sharp, are integrity and excellence. So from a social determinants of health, and maybe some of you are very familiar with this, again, it's recognizing it's a kind of the cohesiveness of social determinants of health, of where your patients are, as well as where they are within the context of a One Health initiative. So it's a nice blending. Healthcare complexity. So we know that there are at least 20 different areas. I've tried to capture as many of them as they are. So if you recognize that that which is above is below, so whether it's the federal government, it's operating locally, we know that whether it's from the lab or through finance or private insurance or ambulatory systems or public health or long-term care, it all goes back up to policy. So you as future physicians, active physicians, you all play a role in policy. So even if you are not lobbyists, you are advocates. You have a much more powerful voice being at the pulse of things to be change agents and to make that difference. And you know, when I'm in DC, and I just came from DC, I was all about that physicians need to be engaged. They need salaries, they need scholarships, they need the National Health Service Corps. They need higher levels of reimbursement. I can't expect more people to say, I want to be like teachers. You know, I want to choose this because I have a passion for it. I don't want you to be burnt out. I don't want you to be rusted out. So what support mechanisms, whether it's in reimbursements, whether it's in salaries, whether it's in scholarships opportunities, that I can do as my part as a servant leader to help keep you engaged and to increase the flock of physicians. So we see in 2023, 2025, so this is what I'm finding in healthcare systems and when I'm in DC and I'm working with the Senate. This is really where DEI, medical innovations and improving health equity, these are the areas that are being adapted. It's your pilot models. So whether it's an ACO, which is an accountable care organization where you all choose to focus on 3 different types of wellness and build consistency for your patients, or whether it's a reimbursement model or an AI model or personalized medicine. Again, I worked many years in genetics and in personalized medicine. That's developing individual best care based on genes and lifestyle and stress to help hit the markers, if you will, for building longevity and diminishing chronic care of the diseases, because you're keeping diabetes at bay, behavioral health, oncology, cardiology needs at bay. It's your virtual healthcare assistants. It's what's called now your digital twins and organ review, surgical catalog suites to help those surgeons have a library of resources. It's infusing through a Laughter MD laughter and how much laughter plays a role in healthcare development and health and abundance through your patients. And what it can even create in oncology care when laughter is applied. Medicine for the masses, which is your DPC, which is your direct primary care. Your medicine and wellness by industry, which is concierge, precision medicine. IoT, which is virtual hospitals and telemedicine, and your preventive health care. So the additional last page on the DEI medical innovations through 2025 are virtual AL augmented realities. It's your doctor pantries, as I'd mentioned before. It's your doctors on the go with the cup of soup, delivering 5 points of care and your toolkits. Your elderly care advancements, recognizing that home health and hospice and palliative care all play an important role. Also, as many of you may know, nursing homes are not profitable. Over half of those that are in nursing homes are on Medicaid, and Medicaid, unfortunately, does not keep nursing homes open as much as we would love to. So it's really going back to, even though home health has not necessarily been profitable, the best type of diagnosis is to put that patient at the center of the care, to recognize that what can we do to keep them safely in their homes as long as we possibly can. It's your diagnostic pocket care, again, another kind of toolkit. It's your EHR, population health, improved algorithms. So whether you're using a Cerner, an Epic, an Athena Health, an ECW, it's recognizing how you build those algorithms for population health through your patients. It's patient accountability. You know, we now have a lot of payer systems, such as Blue Cross Blue Shield, that are now, 30 years ago, it was we paid you for being sick. So the sicker the patients, the better. And then when that didn't work, but we'd gone down that road for so long, we had to revert course. And now it's going to take us probably 20 years to really get back paying according to how healthy you are. So it's now going into the third spectrum, which is payers are paying on how accountable your patients are for their health. So you can make the diagnosis, but now whatever you give them in their toolkit, they're accountable and responsible. So that's the next area of punctuation in the healthcare spectrum, is accountability of patients. It's your 3D printing, it's your implements to organs, it's your 3D pamphlets that you produce for your patients. And if any of you have any questions on any of these, I'm happy to answer them later. It's our advanced mental health care screenings. It's looking at men showing strength through vulnerability, owning up through behavioral health. It's your family care spectrum of health. It's your elder care of health. And then we also see equity and quality through phenomics, genomics, transcriptomics, exomomics. It's your metabolism and metabolics, proteomics, it's microbiomics. So that's your population health stratosphere into DEI along with public health. And again, then equity of workforce. So this is now your fourth paradigm. This is the DEI responsibility for a physician and clinical workforce. So it's assuring a competent workforce, providing evaluation monitors, monitoring the health of one another, diagnosing and investigating, informing, educating, and empowering, mobilizing community partnerships. It's developing policies, enforcing, and the linkages. So hopefully you've been able to see how we've graduated from one of these models into, this is kind of the trifecta, if you will, of DEI at its optimum. Now, I talked about the impact on climate change, human health, and the One Health initiatives. If you take a look at that, it's your weather, it's your air, it's the ecology, it's the allergens, it's the things that basically are seen and unseen, heard and unheard, keeping those all into context, how we're all a part of that gravitational pull, we're all part of that diagnosis, we're all part of that from a community and from a global spectrum. And then the highest level of evolution of One Health is recognizing how does the social determinants of health, how does that fit into that? And we find that we have the social, the economic, the environmental. It's how we think, it's how we strategically plan. It's our working, it's our workforce, it's our adaptions. And it's the sharing, the learning, and the systematicness of the organizations. And then it's also part of recognizing that it's diseases, it's diagnosis, it's your social networks, it's your legal networks, it's your cultural practices, it's your veterinary medicines, bringing them into the social dynamics. It's your multifactorial diseases, it's your infectious diseases. Again, thinking of that from a multi-contextual standpoint. Now, I'm going to apply this to the work that I've been doing as I take the social determinants of health, the DEI movement, the impact on COVID and the stresses, and what I'm doing with the self-care for healthcare and with United Nations and what I'm doing with Jubilee Health. We've developed 6 surveys that we're doing with some of the largest healthcare systems. And we're looking at where are they in their DEI applications? But to be able to garner that, we want to look at real time, where are physicians? And we find that in 2022, that 9 out of 10 physicians reported that their mental health was negatively being impacted, and 10 out of 10 on their physical health. So 9 out of 10 on mental, 10 out of 10 on physical. So it's important that you always keep that context of your own self-care as a huge priority. It's also recognizing that, and we're seeing that in the last year, that self-care and how it relates to DEI is entering into the medical community curriculum. And so I'm glad to hear it and see it. And I just want to reinforce to you how important from the outside looking in that it is to your individual and your university work. It's promoting one, health and safety, maintaining your competence, preserving your wholeness of your character and integrity, and continuing your personal professional growth. I promise by the end of this, I'll actually know forward versus backward. 63% of hospital physicians and nurses report feeling burnout. That is way over the 50% mark. So we know that we need to do some things to keep things in alignment. High levels of burnout impact the patient outcomes and patient satisfaction. When we are recruiting physicians, we are recruiting more than just you as self. We're recruiting your families, and we're recruiting their well-being. And so we know that this has got a larger skipped in what if you're burnt out, you're taking that home. What does that mean? If you've brought your families from across the world here and you're burned out, what does that mean for them and their safety and their sanctuary? 20% of physicians say they want to leave their hospital jobs within a year. And if they've got a student loan to pay, those two really aren't satisfactorily in correlation. So again, what can we do to keep that from happening? 36% of physicians and 52% of nurses are dissatisfied with their jobs, meaning they're not actively engaged. They don't feel present. They don't feel like they're giving back or they're making a difference. So if you know anything about Gallup and Gallup Strengths Finders, they don't feel like they're adapting any of their strengths that they've learned, whether it's their creator skill sets that have been given to them or the things that they've learned through their curriculum. 40% of hospital physicians and nurses report burnout adversely affecting patient outcomes because long before you arrive to ask the patient how they're doing today, they feel your aura and your magnetic field. They know when you're in a funky mood or they know when you're not feeling your best, and here you are treating them. 80% of nurses who you mostly will rely upon to help you are resigning, indicating supervisors as their own key reasons. So again, we're all a part of the whole, and so we have to keep engagement in the context. 20% of nurses intend to leave in the next year, and work-life balance is their primary reason. Self-care for healthcare, we've been able to find just in every 6 months, we check in with our hospitals, and we find that about every 6 months, we save them about $1 million in overhead and recruitment and retention. So I think we're doing the right thing because we're helping you all do the right things. Our surveys are done not only through Self-Care for Healthcare, but they're also done with Medscape. They're done with the Commonwealth Fund. They're done with Becker's, AHA, which is the American Hospital Association. And they're also done with Modern Healthcare. And 13,000 physicians from 29 specialties. We found that 1/5 of the doctors reported feeling depressed. We want them to openly admit that. We want to find people where they really are and to be sincere in that. We can't help physicians. We can't help one another unless we meet one another where we are. And among that group, 24% said they had clinical depression, which constituted severe depression that didn't stem from normal grief events. Among the same cohorts, 64% said they had colloquial depression, such as feeling down, blue, and sad. And that not necessarily was winter or a holiday or a season. They were feeling the blues any given time. And we even had some that said, now I am not only tired of work, I'm tired of life. So again, that is how important diversity, equity, and inclusion, including the humanity of where you are, survey fatigue is real, but it is important to ask 6 really good questions and finding people out where are you so that we can help you level up. Those reported suicidal thoughts out of the medical specialties, 13% were pathology, 11% were general surgery, 12% were oncology, infectious disease, 11% emergency medicine, 11%. Female physicians tend to feel the pressure even more out of balance. part of that is that they're also mothers. And so they, they don't leave and they just turn off their physician switch. They're maternal physicians when they get home caring for their children. And that's not to say partners and husbands aren't doing that, but there is still that kind of matriarch feel that you still need to cook, clean, take care of some of those other things that are just kind of part of being nurturers in motherhood. There's a longstanding expectation that physicians need to be perfect, that anything short of perfection makes for a worse doctor. And I invite many of you to, go to LinkedIn, also take a look at physician and clinical burnout. And there's a lot of good resources there and a lot of good toolkit information that will also, give support to what I'm saying, but also will give you some additional information. Many of the medical community are pushing for fundamental shifts in the paradigm. And again, for a paradigm shift to take place, it's about 35% of your workforce. So in this case, it would be 35% of your physicians. That kind of seems like it's a hefty amount, but that's why we have to constantly clock in and engage with our physician so we can make those critical paradigm shifts. Instead of viewing and seeing mental health as a sign of weakness, we're now really reinforcing that there is great strength in showcasing and highlighting vulnerabilities. So our focuses on self-care for healthcare within DEI are any deliberate act to revitalize mental, physical, and spiritual holistic well-being. It's recognizing that mental health is as important, if not the first priority in your healthcare abundance workforce. And it's an urgent focus of not only on health, but also recognizing that COVID-19 pandemics, whether you were ever diagnosed with COVID, whether you ever received a shot or a booster shot, is not it. But there are long-term effects through COVID diagnosis and long-term stress effects for physicians having treated COVID patients that has caused some of these critical junctures in burnout. We also asked, what are some of the things that physicians are also engaging in? As if your days aren't long enough, we actually do find that there are a lot of physicians who engage in non-balanced work-related stress. They seek out drugs or gambling or vaping or overeating or obesity, versus some of the things that we're really starting to say in storytelling. Storytelling is now, I can't believe it's actually, there are master's courses now for storytelling, that it truly is a leadership quality. Massages, reflexology, chakra alignment, meditation, those are also important. Exercising, dance routines, getting your 10,000 steps in, finding ways that add critical balance and propel you mind, body, spirit, and really circulate yourself. Moral responsibility versus just personal responsibility. You have first do no harm, but part of that is that first do no harm is to not do any harm to your patients, but you have an equal responsibility to not do harm to yourself. And so well-being is paramount to the DEI movement. Good self-care means the world is the best of you. You are the best instead of what is left inside of you. So we recognize that when we teach our components, whether it's in the C-suite or working with physicians or nurses, we have to operate and speak to each of these dimensions of wellness. We can't leave one of them out. So again, if you look at it, that's also, again, your social determinants of health. It's also your patient rounding. You have to self-round with yourself and one another. And it's also the One Health movement. It's also aligning the well-being in the workplace, aligning your values and your brands, because you're each a brand marketing, promoting sociability and knowledge sharing. It's identifying the work settings and enabling the technology. It's empowering your staff through freedom of choice and really harnessing and hardwiring each of your skill sets that allow you to operate at a higher level of efficiency. It's also recognizing who you are as center of patient. You are a patient. You round with yourself. It's putting yourself at the top of priority. Are you spending time alone to meditate? Are you putting yourself first? Are you working out? Are you giving something? I ask people to try to do something for themselves. Recognize that the Creator returned your soul in the morning, giving praise and thanks for another day and what it beholds, to really speak positivity into the universe, that we have an expectation that we will give our best and we hope to receive our best. It's maybe that it's working out, it's maybe that it's meditating, but doing something as a gift for yourself before you ever arrive at work, because throughout the day, you'll be giving 1,000 pieces of yourself away. It's also being grace, giving yourself TLC, forgiving yourself of any shortcomings that you might have. It's also being allowing yourself to draw boundaries and to say no. It's maybe when you get to be at the middle of your career, you say, if I could go back and I could tell my younger version of myself, it would say, it was okay to say no. Sometimes we say yes to everything because we want to learn, we want to actively engage in things, we want to partner, we want to network, we want to build our strengths, find our passions, find out what our higher purpose is. But we also give pieces of ourselves away. Sometimes we want to be people pleasers also, and that necessarily does not do all the good for yourself. So recognizing when no can be the healthiest thing to say. So our program outcomes within Self-Care for Healthcare and our work with Jubilee Health, as well as the United Nations, is we want to promote for our physicians, whether they're doctors in America, whether they're Doctors Without Borders, whether they are doing a piece of Operation Smiles, whether it's that they're part of on the grounds, whether they're in Sudan, whether they're in Ukraine, whether they're in Israel, the Gaza Strip, whether they're in Europe or Mexico. It's recognizing these important principles for the best outcomes. You want to deliver best patient care, but you have to create an opportunity for you to give your care best to yourself. It's improving your patient outcomes and your patient experience. It's creating better employee satisfaction. It's providing culture building, team engagement awareness. It's meeting and exceeding those triple and quadruple aims. It's increasing retention and recruitment workforce, and it's working for better efficiencies and reimbursements. So part of it is, again, this is us in the classroom. It's building accountability, enabling you and your environment. It's creating safe places for access of that information. It's developing key principles, identifying what's important to you as a healthcare system. So part of what we're working on with physician-patient satisfaction is to create surveys, pamphlets, and a strategic plan for adequate staffing. We look at 3 and 5 year staffing for what we know of it right now. We work with the VPs of strategic planning, as well as the COOs, quality CNOs, and our CMOs, for everything that they want to do to prevent staff burnout. Again, our goal is to save the workforce system at least $1 million every 6 months. And that's really important, especially for rural and even larger healthcare systems, so that they are creating a consistency within their community and within their marketplace. It's rotating staff out on high stress assignments. It's taking those mental health breaks. It's implementing flexibility schedules. It's also allowing virtual support. Maybe your physicians can work remote, trying to find that work-life balance. It's a moral responsibility that we have, but that's how we're really building health literacy. It's really how we're building time and appreciation, and really understanding what a contemporary workforce needs so that we can recruit more physicians. And it's recognizing what can we do to lessen depression and to lessen suicide. So some of the areas and the healthcare systems, we have about 100 that we're working with. These are our top 13. Peace Health, which is in the Pacific Northwest primarily, Northside, which is in the Georgia area, New York Presbyterian and Cornell, which obviously is in New York, Massachusetts General, Massachusetts, Boston. It's your VA systems. It's your CHI, or now known as Common Spirit, Houston, Houston Methodist, MD Anderson, Cedars-Sinai, UCLA, Stanford Health, Northeast Georgia. So these are where some of these previous slides that I've been speaking about, this is where we're applying it. And this is where some real results are happening in DEI for physicians. So our awareness opportunities when we're building brands, we ask each of our physicians to build a vision board. How can they themselves reinforce servant leadership? How can you build a culturally appropriate mindfulness presence of who you are? How can we build wholeness, health, and healing of mind, body, spirit into our physicians, and they themselves practice it upon themselves, to their families, to their work, and to their patients? How can we reduce those feelings of fatigue, feeling drained out, burned out, overwhelmed? How can we keep them from being rusted out? How can we build inspiration and appreciation on a reward system? How can we build resiliency, known as bounce back, escalate physician recruitment, increase morale, and build engagement? We actually now are second level when many people ask, well, who else are we focusing on? Believe it or not, it's grade schools and it's middle schools, because they're already deciding what they want to be when they grow up. And we want them to feel a realistic sense of what they'll be getting themselves into. And I like to see that, not everybody can be an NFL player. They can't all be, a celebrity. But I'm really pleased to hear that people are choosing what they used to when I was little. They're choosing being a fireman, a policeman, or a doctor. And that's really, they recognize that it's important to give back. And so I think that there's some sort of social consciousness that when they're on TikTok or they're in another kind of social media, that they're also being very deliberate about who and what they want to be. They know that, to be an influencer and have 2 million people follow them is all well and fine, but a true influencer are your physicians. And so that's who we're working with. There are those future physicians. So it's never too early to get started. Also, it's important for you to know that our physicians are reporting a 16 decrease. Now, these are using these 100 systems that we're in, and the top 13 I showed you. These are some of the results. What does $1 million every 6 months mean? It means 16% decrease in sick days. It means a 21% increase in engagement, 13% increase in retention, 4.93 decrease in turnover rate. Now, our best one is almost at a $2 million save. So that's pretty great. It means a decrease in 33% of those wanting to leave their positions. And you can read the rest of those impressive results for yourself. But we are really creating some high-level, favorable, long-term results. And we've been able to increase, I think, which is really important, your culture. And that's your employee engagement scores from the 50th to the 69th percentile. And again, that's just in 6 months. So that's important. That's how important the work that Dr. Johnson is doing here, how it translates into the healthcare systems in a real world academics application. So our physician learning are our best relationships. So if I ask each of the future physicians to be engaged in other things. I know you study all night. I know you're not getting 7-8 hours of sleep. You're probably getting 2 to 4 to 6 maybe hours of sleep, but it's not regular and it's not consistent. But if you were in another industry or another major, you would be looking at internships. It's never too early for you to get out and do some work with the Doctors Across America, Doctors Without Borders, through the National Rural Health Association, which is what the NRHA stands for, through the United Nations Global Initiatives, through Tribal Health and Refugee Health Services. So if any of you want to be able to give, or as I say, gift back, and you like some opportunities, I'm happy to help you align some of those as well. Those look good on a resume and a CV, but it also helps you to kind of hardwire some of your passions as well. And then these are important toolkits also as an individual, the AAMC and what's being done. There's lots of different journals that are out there. You know, when you've got Christmas, winter holiday off, who doesn't need another good journal to read? Those for community and those, you know, that are portals that you can get inside and take a look at. Again, there's a lot of things in poverty, in social determinants of health, and anti-racism. A lot of things about minority and women. They really break it down quite nicely. And then there's also opportunities for each of you to speak. So not just, you know, kind of intern type ship opportunities or project work during the summers, but there's also different opportunities for you to each speak at, because it's important that you have public speaking skills also. Again, we always do everything from a holistic standpoint, and that's part of our inclusion with some of these organizations. So I ask you to think about, who are you going to be as a physician in your DEI journey? And then I leave you with this thought: 97% of our components in our body are starless, 200,000 star elements. So I ask each of you, what kind of star will you be in this world that the Creator has created you to be as physicians?
I have a question, if possible.
Please.
This is Katie Cohen, the Assistant Dean of Admissions for Creighton and Phoenix. Dr. Rankin, I was just curious, with the recent SCOTUS decision, how are you guys addressing that for your admissions process?
Great question. I would say multifaceted. We have blinded race and ethnicity for our screeners. In addition, we have streamlined the application as well, meaning our interviewers are already blinded to metrics and GPA. But when it came to the deliberation, because someone who interviews is someone who different than deliberates is someone who's different than screening. So many people have hands on an applicant. But at the deliberation phase, we actually have adopted a socioeconomic disadvantage score as well within our institution. And so therefore, we have removed other demographic data that we believe potentially could influence positively or negatively, for instance, an applicant's worthiness. For instance, removing parental information about if their parents are doctors or lawyers, or if their parents didn't attend high school, or didn't attend college, really taking all of that demographic data out, still reporting if they're socioeconomically disadvantaged, EO1 or EO2, but also everyone gets a socioeconomic disadvantage score, so that we're better able to characterize distance traveled, obstacles that were overcome, and really modeling after Dr. Henderson's work, but modifying it at our institution. And so in addition, we revisited all of our policies. We made sure that it was very clear that no one should ever ask about race, even though, we see each other on Zoom. And to be completely honest, we never awarded points for race or ethnicity. We definitely were cognizant of the fact that healthcare disparities exist, and that, we need to improve representation, but we never awarded anyone points for race or ethnicity, or never took away points. We were simply cognizant of the fact that we do want a diverse class, and we want the best of the best.
Awesome.
Hopefully that
Thank you
helps.
so much. Yeah, that's great. Thank you, and wonderful presentation.
Thank you.
I have a question up front. Y'all can hear me, right? Yeah, great. Dr. Rankin, one of the programs that we're really invested in here at Creighton and Omaha is our mini medical school program, which is getting those elementary, middle school, high school kids interested in medicine. Do you have a program like that at Ohio State?
Yes, we do. And it is multi-pronged as well. We have both healthcare exposure, STEM. We also have research. We have K through 12, but we also have undergraduate programs that are aimed at, enriching their exposure and their experience to try and improve their experience with research, their experience with just healthcare in general. So yes, and we actually have a post-baccalaureate program called MedPath. Well, it's not K through 12, but it is a feeder program that students who come from socioeconomic or educational disadvantage, if they're able to demonstrate 1 year of academic success in this program, they have conditional acceptance into medical school. But yes, we do have K through 12, and it's not only just through the medical school, but we have the 7 health colleges. So we have nursing, we have pharmacy, public health, and they all have outreach for K through 12. In addition, our student interest groups really do a fantastic job. We have this program called MD Camp, which focuses primarily on high school students coming and spending 2 weeks out of the summer on the medical campus.
Thank you.
Dr. Ali-Dinar, would you please talk about or offer your thoughts about adversity statements? Well, at Ohio State, they have these, we were talking about these scores that you give. You give a numeric index for a person coming through some kind of unfortunate experience. There was a paper presented at the AAMC that talked about the importance of the SCOTUS decision, looking at ways in which applicants could craft adversity statements to help massage their application process and kind of communicate the experiences they've had that they believe negatively, consistent with the Supreme Court ruling, impacted their ability to kind of ascend into medicine. And so now statements are going to be modified, I think, to incorporate adversity factors that applicants believe adversely prevented them from making their ascent and what they did to overcome that.
More on the process of, I mentioned storytelling, and that we each have a powerful testimony of how we grew up, what we had for resources and sources, what we had for a support system. So we haven't been more actionably involved in the SCOTUS outcomes or the adversity statements as they're called. We try to integrate within the workplace, within recruitment and retention, what we call storytelling, where I guess from a more politically correct, knowing that we work on a broad base, even internationally with healthcare systems, to say storytelling. Give us the power of the experience of how you grew up, where you grew up, and using those gaps that would have otherwise been seen as deficiencies to see them as strengths, to see them that is the context of the real world. It is not the silver platter that's feeding the global society today. So we really see it as storytelling, that layman's term, if you will, that everybody can adapt to, and that we're all a brand. You know, we all have a story, we have a shell, we are empowered. And what is that? And we use that more of as a recruitment retention tool, an interviewing tool, and that seems to work very favorably.
Dr. Rankin, did you hear that? Dr. Johnson asked if you had any thoughts about that as well.
Oh, yes, thank you. No, I think that is a very beautiful way to capture it in terms of storytelling. I think students need to understand that are applying to medical school, they absolutely should feel empowered to describe who they are, what their motivations for medicine are. And it's no different. You can't tease away race, ethnicity, religion, the experiences that everyone has had, because that is who you are. Just as much as I am a female and my experiences in life as a woman may have motivated me to pursue medicine. So it's really a matter of who you are and not singling out that one particular aspect of who you are as the only reason. That's the motivating factor. So I believe the storytelling is absolutely very, very much important. And you have to understand, you have to be able to explain why You know, a lot of times the why when we're looking for in personal statements or other essays is, why do you want this? Why do you want this? And so that is a part of the storytelling. So, and I guess my other statement would be that I think we're still relatively early in this process, and I think there should be some caution exercised in overcorrection or overextension of what the ruling was. The ruling never said students couldn't talk about who they are or their motivations or things that are important to them. Medical schools or higher educational learning centers simply can't use race as the determining factor as to why someone should get in. But students absolutely should feel empowered to talk about who they are, why that is pertinent to their motivations of wanting to pursue medicine.